All right, good morning everybody. First up on our case list today, we're talking about Abba Adore, and we need to come up with her care plan. Over to you first, Dr. James.
So we've got Abba. She's a 55-year-old Ghanaian female that has got adenocarcinoma. We performed a CT scan, bronchoscopy and a biopsy. She lives alone, she has limited English, small amount of social support. We just need to decide what we're going to do. She wants treatment, but her family is important to her.
We have consistently used translation services. Her English is not fantastic, but her understanding is improving. We're trying to do it at her pace, but time is of the essence.
But we need to consider her emotional readiness as well. We need to think about it. It's not only about treatment, isn't it?
With respect, we don't have time. We need to act sooner because the tumour is progressing.
Acting without emotional readiness is unethical.
Exactly. We need to
increases the trauma.
We need to balance it. We need to balance the compassion with the treatment planning. We can't just dispute it. You need to listen to us.
If we wait too long, we will lose the window of opportunity for a curative treatment.
I agree with Dr. Jones. Based on the stage of the cancer, we need to be very specific in our timelines.
But she's not ready. She's weak. She's fatigued. She's still processing what's happening. We need to look at these things. She's worried. She's asking about what are the consequences of these treatments. How would she feel? Would she be able to walk to the shop? We need to consider all of those.
I am worried about her sleep.
Yeah.
Maybe some sedatives.
Right, you're being all really compassionate, and I get all of that, but the bottom line is that we need to act soon, quickly.
Exactly.
But what about quality of life? We're not just talking about survival or not survival.
I'm not saying that we need to ignore all of that, but we need to come up with a plan now that gives us the best opportunity of a curative treatment. What about radiology?
Well, radiotherapy is an option, but the vascular structures that are under this tumour.
So we need medical imaging to give us the best idea as to what we should do. Is that correct?
Yes. However, that does not change the fact that if you overtreat too quickly, you might cure, but you'll also kill.
So what other options have we got then? What about chemotherapy?
Can I just say that pathology has already confirmed that it's an adenocarcinoma and there is no EGFR mutation. However, we are still waiting for PD-L1 results for the immunotherapy.
Which doesn't matter if she's dead because you've treated too quickly. With radiation.
I'm sorry, but every time palliative care is mentioned, you treat it like a failure.
It's not a failure. But we need to look at curative options first.
Exactly, we do.
Are we giving her false hope?
Right, we've got three options, as the way I see it. So we've got chemotherapy with support. We've got radiotherapy if it's appropriate. And we've got palliative care with support.
I'll get some translated leaflets and prepare some visual aids for her. It's important that her consent is truly informed and we run it at her pace. Yeah. I think we need to do a referral to get psychology involved and perhaps to the dietitian. Is that something you can help with?
We just need to come up with a plan.
Macmillan can also support with psychotherapy or counselling, and we can also refer her to a dietitian or other departments required.
Good idea.
I will coordinate logistics and I will make sure that she has an interpreter every time she has
So let's just ensure...
Can you please give us a chance?
Stop all talking over each other.
She needs support.
This is not helping at all.
Okay, at this point I need a plan. So what are we giving to this patient?
So we need to have a plan that provides clarity, that has compassion in it,
Yes.
and
Finally.
respect, even if we don't all agree.
And bearing in mind the stage of cancer.
Yeah.
We need an interpreter. She needs someone to explain these options to her. We can't just rely on the brother or the family. She needs someone.
We need to make the decision as to what's the best plan that's going to give her the best opportunity of it being successful.
Dr. Jones, with all respect, you're not listening to all of us. We're trying to help this lady. And all you're thinking about is just treatment options. We need to think of her.
No, but Dr.
No.
Jones is looking at the clinical aspect of it and the prognosis.
Prognosis is directly linked to her emotional status. We need to show compassion.
And prognosis should lead to a quality of life.
We do understand that, but the reports, the diagnosis, the pathology reports are all saying that we can't delay it anymore. We can't.
But the patient isn't the tumour.
Okay. Okay. So help me. We've got a clinical plan.
Mm-hmm.
You've got your plan.
Nursing plan.
Nursing plan.
I'll go and talk to medical physics.
Okay.
I got psychotherapy covered from Macmillan.
All right.
And
Okay.
we do have immunotherapy if needed, based on the PDL reports that we'll get.
It is policy to use a translator, but they're not always available. are
No, I'll just make sure that she's got someone to contact whenever she needs it.
All right. All right. So we've got our plan. Okay. Let's reconvene in 72 hours. Once Ava's had the discussion with us, and then we can readjust afterwards. Okay. Happy?
Mm.
Mm.